One row you will mark absent, this side 2 rows you will mark absent. Okay, good morning. I think last Friday it was holiday because of Holi, so probably you guys missed out. So there was no lecture actually. And before that, on 7th, I was supposed to take a lecture on affective disorders. Unfortunately, I was traveling, so a topic of psychological first aid was taken. Is that right? Did you guys attend it? ठीक है, जितना याद है. Do you think it is useful to help our colleagues if they are in distress? हमने क्यों से यस. अभी कुछ ज़्यादा ही टाइट हो गए ना आप सब लोग सीट्स के चक्कर में. So one of the important things that I keep on emphasizing is that you need to understand your own emotions and you need to understand the emotions of your friends and also of your relatives. If you are able to do this empathetically, this will help you quite a lot in your own personal growth. And at the same time, you would also be able to prevent certain mood disorders that are likely to take place. So I'm not going to spend too much of time today because we've already done a basic introduction to mood disorders in the earlier class, which was probably before 7th. So that would be last date of the month of February. So mood disorder is a characteristic disorders where the illness happens in discrete episodes. Unlike schizophrenia, which is a continuous disorder, mood disorders are episodic disorder. The only exception being dysthymia. Okay, and we'll be coming to that. So the kind of episodes that you can have in a mood disorder can be either a depressive episode or a manic episode. Depressive episode can be specified further based on its severity, called as mild, moderate and severe. It can be specified in relations to the symptoms that they have. So you can have additional psychotic symptoms, you can have additional anxiety symptoms, you can have additional somatic symptoms. So somatic symptoms is basically aches, pains, abdominal symptoms, urinary or genital symptoms, headaches, so on and so forth. Then you can have atypical symptoms, which is characteristically the opposite of what is expected in case of depressive disorder. So for example, you would expect morning worsening of mood, but in atypical you will have an evening worsening of mood. You typically would expect insomnia, but in case of atypical you will have hypersomnia. You usually expect decrease in sexual drive, you can have an increase in sexual drive. So all of these features are possible in atypical depressive episodes. And next one is the melancholic. So melancholic is characterized by a feeling of heaviness in the limbs, so much so that you don't feel like moving your limbs. This kind of picture is typically seen in people who crave for chocolates, and it also can be seen in those who are very sensitive to rejection. So those who get offended very easily, these kind of people will tend to have a melancholic episode. Depressive episodes can further be specified in relation to the seasons, that typically is seasonal affective disorder. Can also be specified in relationship to the menstrual cycle or the menstrual phase in which the particular set of symptoms occur. Manic episodes can also be characterized by severity. So just like we have mild, moderate and severe in depression, the mild form of manic episode is called hypomania. The moderate or the severe both can be clubbed as mania. And in case of mania, we have something different, which is called as mania with psychotic features, which is supposed to be a very severe form of manic episode. Manic episode can also be specified in relation to the evolution of symptoms. So typically patients who have a manic episode usually turn out to be bipolar disorder, And some patients with bipolar disorder tend to have the characteristic symptoms of schizophrenia going along with it. So this kind of disorder is called schizoaffective disorder. So based on what we've studied now, there are different kinds of disorders that are possible in mood disorders. These I'm just naming them right now. Major depressive disorder. The names that I've used are from DSM-5. So in ICD-11, you might find some variation. So a major depressive disorder, a premenstrual dysphoric disorder, seasonal affective disorder, postpartum depressive disorder, bipolar 1, bipolar 2, cyclothymia, and dysthymia. So again, going back to the episodes. So depressive episode is characterized by 3 core symptoms, and we've done this previously, but just to revise, there is a pervasive sadness of mood, okay, which is basically a change in the quality of mood. So it is not something that has happened back to you. It's just that you don't find it exciting enough. So you're finding it very dull, okay. So it's very difficult to explain, but those who have experienced this would understand as if everything is very dull, dark, you just don't feel like moving out of the bed or moving out or moving about. Then you have a second characteristic symptom called as anhedonia, which is loss of pleasure in one's pleasurable activity. So it's very important that you used to enjoy it before you say it is anhedonia. And third characteristic symptom is decreased energy or easy fatigability. 2 out of these 3 symptoms, remember this, 2 out of these 3 symptoms should be present for a period of 2 weeks or more for it to be called as a depressive episode. So something that lasts only for few hours, few days does not characteristically fall under depressive episode. So if you happen to have a breakup, if you have failed in some paper, something bad has happened at home, and you tend to have these symptoms, but these symptoms tend to go away in a period of less than 2 weeks, then that would not be called as a depressive episode. Instead, it would be called as an adjustment disorder. And I hope in the previous lecture by Dr. Ashish, you would have understood what an adjustment disorder is. Now, the important thing to know in this definition is there is no mention of suicide, suicidal ideas, suicidal behaviors. And another thing to note is there is no mention of any stressor. So you do not require a stressor to make a diagnosis of depressive episode. You do not need to have self-harm behavior to make a diagnosis of depressive episode. Now, along with these characteristic symptoms that we just mentioned, you can also have cognitive symptoms, vegetative symptoms, and somatic symptoms. So cognitive symptoms include poor attention, poor concentration, recollection difficulties. The patient typically would report that whatever he's studying for or whatever he's working in, he's just not able to recollect the facts that are already known to him or that he has just acquired. There is a decrease in self-esteem and confidence. So a person who does not have a courage or to do even simple activities, for example, like attending classes, giving the part exam, or in terms of adults missing out on meetings, okay? Then there is pessimism and brooding. So pessimism is that you do not have very optimistic view about things that are going to happen in the future, and brooding is recurrently thinking about past events typically associated with failure. Then you have Beck's cognitive triad, which is a triad of hopelessness, helplessness, and unworthiness. So these are the characteristic symptoms. If any one of these 3 symptoms is present, hopelessness, helplessness, and unworthiness, this is typically associated with suicidal behaviors. So whenever you assess for a patient with depression, you have to look out for these 3 particular symptoms. Then you have unreasonable guilt. So you might have regret over past events, but events that have not gone your way, for which you cannot be blamed, you also take blame for that. A typical example usually is when a person reports that when his or her mother was not well and that person eventually died, they take the blame on themselves that they did not do enough, okay? But you can have various other forms of guilt. Then you have vegetative symptoms, which typically is decrease in sleep, decrease in appetite, decrease in sexual drive. But once a while, you also get the other way around, where there is increase in sleep, increase in appetite, and increase in sexual drive. One cognitive symptom that we are missing out is suicidal behavior. So you can have ideas of life coming to an end. So this is called as death wish. So you would desire that my life should end. You do not have any plans for it. You do not have any method that you have planned. So from death wish, you go to suicidal ideation. When you start thinking about what would be the best way to die, You start looking at the pros and cons, which would be the most painless method, which would be a method by which nobody would know. And then you start actually planning it. And then you start collecting material for whatever way you want to attempt suicide. And then finally you attempt suicide. So characteristically what is seen is males tend to be successful in their first attempt. Females may require 2 attempts or more. This is a spectrum. This does not, from death wish to suicidal behavior, does not happen in terms of minutes. It takes few days, and this is the most appropriate place for intervention. People who have death wishes, till the time they have active suicidal behaviors, they would tend to express this, and this is very important to remember. A person who has death wish or is planning to attempt suicide is some way or the other going to communicate this to you. It may be verbally, most likely, or it can also be non-verbally. And this is what you need to pick up. If you identify these depressive spectrum behaviors, then you should be immediately hospitalizing this person. Somatic symptoms that I have told earlier, these includes non-specific aches including headache and heaviness of limbs. Apart from the typical core depressive features, you can also have features that are associated with other disorders. So you can have anxiety symptoms, that is a feeling of impending doom. This can be associated with autonomic arousal, that is, what is autonomic arousal? Anybody? Tachycardia, tachypnea, sweating, tremors. Okay, so there are about 16 such symptoms. You need to be aware of them. In a depressive episode, you can also have obsessive compulsive symptoms. They tend to occur after the onset of depressive symptoms. Then you can have psychotic symptoms like the presence of delusions and hallucinations. Okay, now we are moving to manic episode. Like in depressive episode where you have 3 characteristic symptoms, 2 out of which should be present and then you can make depression. In case of mania, it is not that clear. So what is, you have a group of symptoms, and if you have a specific number, either 3 or 4, you can be able to make a diagnosis of a manic episode. So this is characterized by a pervasive, cheerful or an irritable mood, increased self-esteem, expansiveness and grandiosity. So a patient would say that I can do things, he will start doing things for others, that is expansive, and then really start believing it and start acting accordingly. You can have increase in speech, that is increase in the rate of speech production. So your rate of speech production typically is about 80. In these patients you can have about 150 or more, so which is a very fast speech. You can have increased socialization, that is a tendency to interact with others. You can start interacting with familiar people, then unfamiliar people, and then absolute strangers, and you can go about talking and chit-chatting about anything. At times this socialization becomes embarrassing. So you can start talking about views or topics which people are very uncomfortable discussing either in a public place. There is an increase in goal-directed activity. So if you have 3 tasks to complete, you would start all the 3 tasks simultaneously. If you have any plans to wake up in the morning and do so and so things, you find that energy to do that. So this kind of increased activity is actually very helpful. And what you would know is, if you start finding about public figures who have bipolar disorder, they tend to use this as an aid to improve or accelerate their career. So one typical writer who is very famous, and I would want you to find out about him, would induce hypomania by the use of drugs, and that would improve his ability to write novels, and he would be able to write more novels more faster and communicate things more effectively. So there are people who would want to be in a hypomania phase. Okay, then you can have so the increased productivity is at a very minor threshold, but when you start planning too many activities, you tend to become distractible. So instead of completing any one task, you start having all the tasks incomplete. A woman typically gets up in the morning, starts washing her clothes, doing all household work, waking up the kid, and at the same time listening to songs, dancing along, and things are happening so haphazardly that the child is not yet ready to school, the home is not yet clean, and all of this is going on beyond a stipulated time. There is a decreased need for sleep. So in case of depression, the person wants to sleep, goes to sleep, but wakes up early. There is insomnia in a manic episode. A person doesn't want to sleep, eventually lands up sleeping, gets up fresh, even if it is 3 hours sleep, feels very energetic and starts doing all the activities. So there is a difference in the insomnia both in depressive episode and a manic episode. The appetite can be variable. There can be increased appetite also and decreased appetite also. Within the episodes also you can have a change. So for few days a person is having increased appetite, ordering lot of food from Swiggy, Zomato, and then all of a sudden not eating anything for days together, start believing stuff that cannabis is good enough for him and that he can survive on it, so on and so forth. The sexual drive is usually increased, so there is no decrease in sexual drive unless and until spiritual symptoms are spirituality is also associated in that particular episode. So those who tend to so like the last point, increased religiosity and altruistic behavior. So these kind of patients who would start believing in spiritual stuff then would at least express a decrease in sexual drive. There is an increase in risk-taking behavior. So that can be either taking drugs, indulging in unprotected sex, rash driving, so on and so forth. There is an increase in religiosity. So there is long hours of prayers, long hours of meditation. There can be a lot of donations that are given to people. I had one patient who gave a 1 lakh rupee ring just because the barber did a decent haircut. So 1 lakh rupee ring, he just gave it up. Then there can also be a lot of activism. There is a dissatisfaction with the way things are not moving, something needs to be done, I will do it, let's gather together. So that person will rally around people, make issues out of very trivial things. So such kind of activism can also happen in a manic episode. So when you have these symptoms which are in a very minimal form, but which are not the person's personality and have minimal dysfunction for a period of 4 days or more, this is called as hypomania. Okay, so repeating this again, mild symptoms, minimal dysfunction for a period of 4 days or more, it is called hypomania. And when you have moderate to severe symptoms with significant socio-occupational dysfunction, so it is hampering your daily activities, it is hampering your self-care, it is hampering your education, it is hampering your vocation, and these symptoms are there for 7 days or more, this episode is called as mania. Now the only reason why we have this distinction is, in nature you have two different disorders, bipolar 1 and bipolar 2, and in bipolar 2 you will characteristically see only hypomania, you will never see mania. So based on this, we just saw the overview of all the disorders. So we'll just characterize each of these disorders into the number of episodes that they have. A depressive episode, a major depressive disorder, is a disorder in which there is a single or recurrent episodes of depression with any severity. So mild, moderate, severe, kuch bhi ho jayega, chal jayega, but the person should have recurrent depressive episodes only. Seasonal affective disorders, single or recurrent episodes of depression, but in context to change in the sunlight exposure. So not exposure per se in the sense that how many hours that person is spending outside in the open space, but it basically means that there is a change in the sunlight exposure. So typically in temperate climates, you would have people who are having seasonal affective disorder. Premenstrual dysphoric disorder, this usually is after 15 days prior to the onset of menses and is relieved after the onset of menses. You have postpartum depressive episode, which starts within 1 month after the delivery and can last up to 6 months. So all of these are depressive episodes only. They have the same characteristics that we have explained in the earlier part. And here we have the bipolar disorders. So bipolar disorders are distinct episodes of mania and depression, and it has to be mania. At least one episode of mania, not hypomania mind you, one episode of mania should be there for the disorder to be called as bipolar 1 disorder. In bipolar 2 disorder, it's same as bipolar 1, but none of the manic episodes should reach mania. They should only and only be hypomania. Then you have cyclothymia, where you have a characteristic cycle. So you have a phase of hypomania lasting for few days, and then you have a phase of low or mild depressive symptoms which can last up to few weeks. So continuous fluctuation. This kind of patients are typically called as moody people. So all of a sudden you would find a person who is very cheerful, very energetic, very talkative, socializing with you, being very funny, and then all of a sudden this person is not found anywhere, is sulking, is not talking to anyone, is not socializing, and then all of a sudden after a few weeks again the episode starts. Now one thing that you need to understand is patients with bipolar 1 and bipolar 2 usually have a period of euthymia. Euthymia means they are neither in a depressive episode, neither in a manic or a hypomanic episode. So these people, you need not assume that they are always in some or the other episode. For almost 75% of the time, they may not be in any episode. Okay, and they are functionally as good as any one of us. So it does not mean that somebody has bipolar disorder, he or she will not be able to pursue her education, vocation, cannot have a family life, nothing of that sort. They can absolutely do all of that, provided they don't harm themselves in any of the depressive episode. Then you have dysthymia. Dysthymia is chronic, persistent, low-grade depressive symptoms which last for 2 years or more. And this kind of disorder usually starts in the early adulthood and it stays on forever. So these patients are usually not able to enjoy most things in life, and what the only thing that they enjoy is work, and they eventually end up becoming workaholics because they do not find pleasure in movies, in socialization, in going out. The only thing that they find themselves worth is in working, and they would tend to work quite often. These people would also indulge in illicit substances. So they will be smoking, they would be into alcohol use. The use may not be restrictive in the sense that they will not have just 60 ml or 80 ml, 100 ml. They may also escalate their alcohol use. Okay, so now we are going to disorders. Major depressive disorder, as we have discussed before, is a recurrent episode of depression. This is a very common mental health disorder. There are 4 mental disorders which are supposed to be common mental disorder, and there is an emphasis of WHO that common mental disorders should be identified in the community and should be treated as early as possible. The 4 mental health disorders are major depressive disorder, anxiety disorders, OCD, and somatoform disorder. You would be surprised that depression is among the top 10 causes of morbidity and mortality across the world and also in India. So where you have cardiovascular disorders, you have neurological disorders, you have cancers, depression stands right between them. A lot of people are not able to go to work or are prematurely terminating their life, and this is a significant health issue. The lifetime prevalence is supposed to be about 15%, but there are many studies at least 10 years back which are projected by 2030 that the lifetime prevalence is going to increase by up to 25%. Okay, but we are not seeing that as much. The incidence is about 5% across various settings. The usual onset is 3rd decade or later. The incidence is very high in the 4th decade. The incidence is also higher in females in a ratio of 3:1, and the disorder is more likely in migrants, those who live in the urban cities, urban places, and those who have a traumatic childhood experiences. We'll briefly look at the various etiological theories. So we have the neurobiological theories and we have the psychosocial theories. The neurobiological theories include the monoamine hypothesis. So if you just recollect all the 3 characteristic symptoms of depression, you have low mood. Mood is typically serotonergic. Then you have anhedonia, that is loss of pleasure. Pleasure is usually associated with dopamine. And then you have decreased energy or easy fatigability. Energy symptoms are typically associated with non-adrenaline. So this is the monoamine hypothesis, which says that either one or more of these monoamines are deranged. What we do not understand as yet is why do they derange episodically, and how is it that acting on one particular neurotransmitter is helping us? Because if you remember the classification of antidepressants, we had drugs which are serotonin specific, then you have drugs which are norepinephrine specific. Okay, these monoamine metabolites can be found in various tissues, and these metabolites have been found to be in a reduced quantity. So in brain tissues, you have reduce of reduce of the serotonin metabolite. You can also have a reduction in the CSF, and also when these metabolites are excreted, the excretion is also low. Then there is a newer hypothesis called the glutamatergic hypothesis. Anybody who knows Chandler का नाम क्या था? Chandler Bing in Friends, what was his name? Chandler Bing था ना? Matthew Perry. So Matthew Perry died because of ketamine overdose. Ketamine is a drug which acts on the glutamatergic system. He was in depression, that's what is there in the news, and he had overdosed himself with ketamine. So this is the glutamatergic hypothesis. Then this is an old hypothesis called the HPA pituitary axis dysfunction hypothesis, which states that because there is presence of chronic stress, there is a blunting of affective responses. Typically, HPA axis dysfunction is done by a dexamethasone stress test, where a dose of dexamethasone is given, and then there is a blunting in the ACTH response. This is a very old hypothesis, and although it is true, we are not too sure if it is contributing to the etiology of depression. Then functional brain imaging studies have shown that patients with depression have what is called as hyperfrontality. So if you are given a task, then your frontal region becomes active and starts executing the task at hand. What happens in depression is that there is no activation of the frontal region, and because of this, these symptoms appear. Now we do not know if this is etiology or this is just an association. Okay. In terms of genetics, there is a concordance in monozygotic twins, about 45%, and in dizygotic 20%. First degree relatives are 3 times more likely to have a depressive illness. Then you have very interesting psychosocial theories. So before neurobiology came into the picture, there were many theories trying to explain. They started with Sigmund Freud, and then there we had the behaviorist, and then we have the cognitive theorist. So Sigmund Freud and his colleagues said that this is basically anger which has been turned inwards, which has arisen because of an object loss. So that object can be anything that is dear to you. It can also be hypothetical, for example, love. And you can because of that loss, you would have an anger which is directed inwards. And this is the psychodynamic theory. Then we have a behavioralist. So behavioralists are those who believe that if you give something to the student will reciprocate in good activity. So I was talking to Misbah, all of you changed your seat. So this is a behaviorist theory. And one of the theory is given by Martin Seligman. And Martin Seligman is a pioneer person, and the experiment that he did was, he had dogs, and then he would put them in a cage, and then he would electrocute them. And then the dog would run helter-skelter. He would then again repeat the experiment. All of this was associated with an alarm. And then what he realized was the dogs, after a certain amount of time, got used to those shocks and they stopped running around. And they would just sit and wait even after the alarm. They would take the shock very well and still sit. And eventually their activity decreased. So this was the learned helplessness theory given by Martin Seligman. Martin Seligman believed that when a person is in a situation from which they cannot get out, they tend to withdraw. And this was one of the theories. Now Martin Seligman, in his own this particular experiment, realized that 1/3 of the dogs would keep on making effort irrespective of the number of shocks. So even if they have been electrocuted for days together, they would still find a way to escape from that particular cage. And this was the birth of positive psychology. And this is what is called as resilience. So despite you having multiple failures, you have a tendency to bounce back. And this is the basis of positive psychology. And this is what all coaching and all is all about. So if you positive mental health coaching, those who are into personality development, all of them are using this theory. Then you have the cognitive theorists. So there is a particular theorist called Beck, जिनका नाम हमने पहले भी लिया था. And Beck noticed an interesting thing. He was a psychodynamic person, but then he realized that it is not completely answering the questions that the patient is putting forth. And he identified particular set of symptoms, and they are minimization, maximization, overgeneralization, labeling, jumping to conclusion, catastrophizing, and personalization. So all of this needs to be explained in a bit more detail, but what you need to understand is when a person is in a depressive episode, their outlook towards events that are happening is very different. So there can be minimization, maximization. So for example, something good has happened is considered to be luck. I had nothing to do with it. I didn't work that hard. मुझे तो marks ऐसे ही मिल गए. Getting it? And then there is maximization. So things that have happened very small or trivial. Friend did not sit with you. I am not liked. I am hated. People don't like me. They run away from me. So small events are either taken minimally or in a exaggerated form. Overgeneralization. One event in one circumstances is supposed to happen in multiple circumstances, and all of them are taken in a negative connotation. Labeling. If I don't get good marks, I am a failure. I am not only failure in studies, I am failure as a son, I am failure as a family member, I am failure as a friend, I am failure as a lover. My life is all about failures. What has happened? You have just scored poorly in an academic exam, but you extend that label all across. Then jumping to conclusion. So events that have not yet completely unfolded, you start predicting. You're planning to go out, you're not getting a cab, this is a bad idea. There's no point in going to movies and going out to eat. Getting it? So basically something small or trivial has happened which can be sorted out, but you start thinking about bigger things. And this is same as catastrophizing. So jumping to conclusion is you conclude it is a bad idea. Catastrophizing means it is going to collapse completely. And then personalization, where things and events which are not related to you, you start believing they are related to you. Okay. So these kind of distortions Aaron Beck found in his patients, and he started working on these distortions, and that was very helpful for treatment of depression. Then you also have predisposing personalities like the anxious avoidant traits, the anancastic traits, and the dependent traits. So you would be doing personality class. All of this is cluster C personality disorders, where a person tends to stay within himself, not to interact much with the social environment. Now, major depressive disorder can look like other disorders, and these are the disorders that you need to rule out. So remember one thing, there is no test to diagnose depression. There is no blood test, no CT, no MRI, no test that is required to diagnose depression. It is purely a clinical diagnosis. However, before you make a diagnosis of depression, it is prudent to rule out if there are any other disorders which are likely to present with symptoms of depression. So one of the things that is very fairly common in India is anemia. You have low hemoglobin, so you have decreased energy, and you also have aches and pains, and you tend to believe that this is depression. It may just be simple case of anemia. You treat the anemia, a patient will start feeling better. Post-viral symptoms, any prolonged infection, tuberculosis, HIV, AIDS, typhoid, all of them can have symptoms which are suggestive of depression. Endocrine disorders like hypothyroidism reduce testosterone level. So this is a finding which is fairly common in the US. I don't know why it is not so common in India. So in US, if you have depressive symptoms, they tend to also have males and females both tend to have a reduction in testosterone levels. And I'm told by my friend that giving testosterone injections is fairly common practice in the US. I don't know if that's true or not now. Uncontrolled diabetes is also a reason that can feel like it is a depressive episode. Neurological disorders that have similar features but not completely include tension type headache and neurodegenerative disorders like Parkinson's and so on and so forth. Even in malignancy, you can have a feeling that a person is having depressive features. So what are the reasons for hospitalization? You have hospitalization if a person expresses suicidal ideas, plans or attempts. There is a deterioration in functioning. For example, there is no proper self-care, person is not bathing, is not having food on time. Then there are symptoms suggestive of catatonia. So I don't know if you have a lecture on catatonia, but in catatonia you have various symptoms, and among them is mutism, stupor, waxy flexibility, so on and so forth. And if you have presence of any psychotic symptoms, that is delusions and hallucinations. Just like to point out, in depression, the delusions and hallucinations have a different quality. In hallucinations that are happening in schizophrenia, the hallucinatory voices are continuous, persistent, and occupy the most of the time. Whereas in depression, there are very short sentences, occur very infrequently in the day, and are in context to the depressive symptoms. So a patient with depression reporting hallucination will say, I get voices which say, Marja, Marja, tu ganda hai, tu buri hai. and they happen 5 to 10 times in a day. Whereas those in schizophrenia are reporting continuous voices. There is a person, he's talking about me, he's noting about what I'm doing, he's noting what I'm moving, what I'm eating. So the voices are very continuous in case of schizophrenia. So how do you manage major depressive disorder? You have pharmacological methods, you have non-pharmacological methods, which can be psychological interventions, or it can also be biological therapies. So you must have learned the classificatory system of antidepressants in your second year. We typically give one antidepressant at a time. Please remember, unlike fever, when you have paracetamol and the fever goes away, this does not happen in case of depression. You start treatment and then you escalate the dose. Your response can take anywhere between 2 to 3 weeks. So first 1 week, your patient may not be having any kind of improvement. Okay. All drugs are equally effective. We have so many drugs and all of them are equally effective. Nobody can say that this drug is better than that drug. However, there is a difference in tolerability. So if you have someone who is taking TCAs, will have too much of sedation, urinary retention, constipation, so on and so forth, and they would not want to be on that particular medications. When a person is on SSRI, there are fewer side effects, and that is what a patient might prefer. You also have to use these medications in a sense that the side effects are to your advantage. Okay, so anything a person is reporting insomnia, you want to give an SSRI, you would prefer paroxetine. Why? Because paroxetine causes sedation. You have a patient who is reporting predominant cognitive symptoms, unable to focus, not able to stay awake, remaining drowsy. You would use something like fluoxetine. Okay, this does not mean paroxetine is better than fluoxetine or fluoxetine is worse than paroxetine. So the idea is to use the side effects of drugs to our advantage. Okay, once you put a patient on antidepressant, 1/3 patients would respond. Then you will have to switch the antidepressant, and then again 1/3 patients would respond. There is no typical pattern that this should be the ideal first drug and this should be the ideal second drug. Okay. Sometimes what happens is you have a partial response, and at that point of time you need to use augmenting agents, and the commonly used augmenting agents are lithium, levothyroxine. You can use low dose antipsychotics and in doses which are not for psychotic disorders. So olanzapine, for example, is used between 10 to 20 for schizophrenia. In case of depression, you might use something between 5 and 10. Similarly, you can use quetiapine and aripiprazole. Buspirone augmentation can also be done. One combination is typically, I wouldn't say recommended, but it has been found to be very useful. And this is a combination of 2 antidepressants, and it is called venlafaxine-mirtazapine combination. It's also referred to as California rocket fuel. I do not know the reason for it, but this combination is found to be very useful. Then you can have psychological interventions. Psychological interventions include supportive therapy. So basically problem solving. You have some issues that you're not able to deal with. For example, there's a person who is usually having issues of procrastination, and this is the reason why they find themselves stressed, and then you deal with the procrastination habit, and that helps you out. The second psychological therapy is behavior activation, which basically is seeing to it that the day structure of the person is maintained. And the day structure also includes other activities, for like example, going for a walk, going for relaxing sessions, going to friends, meeting relatives. So the day is structured in such a way that the impact of depression is felt minimally. Then you can use the BEX therapy, cognitive behavior therapy, which focuses on the thought processes that are involved. You can also have dialectic behavior therapy, which deals with the way you process your emotions. So events that happen and then you start feeling sad, you start working on that particular aspect of sadness. Many of the patients with depressive disorders also have interpersonal issues, and this can be dealt with the interpersonal therapy. Psychodynamic therapy can be used. Unfortunately, it's not that fairly commonly used in India. Then you have a range of biological therapies. So biological therapies are interventions that do not involve drugs, although ketamine you can say involves drug. But this is not something to be given in a continuous fashion, so you give them in a discrete cycles. So if you have heard of electroconvulsive therapy, anyone who has not heard, so ECT is probably the most effective intervention for depression, okay, and it is probably the first indication for giving ECT also. So ECT, आप लोग सब लोग अपने YouTube पे Peters ECT एक बार ढूंढिए, and Peters ECT is just the way ECT is done all across the world. We also do it in that particular fashion. So in case if you have not been able to attend ECT during your ward posting, you can have a look at that particular video. Then you have repetitive transcranial magnetic stimulation, and this has an interesting history. Patients with depression who, when sent for an MRI scan, were found to have improvement in their depressive features. So this just did not make sense. And then what they did was try and having ECT or the seizure associated with ECT with the use of magnets. And this is what is called as repetitive transcranial magnetic stimulation. Because the seizure that we need is in the frontal lobe and not in the parietal lobe, we do not actually need the hand and legs moving. All that we need is a discharge in the temporal or in the frontal region. This can be done as an awake procedure. Okay, so you don't have to sedate that patient, do not need to paralyze that patient, and this procedure can still be done. Then ketamine therapy, where ketamine, as you know, is an anesthetic agent, but in a low dose when given as an infusion, this leads to a dissociative state. And after coming out from that particular dissociative state, it has been noticed that people tend to have improvement in their depressive symptoms. In fact, it is almost magical because no other treatment can show immediate response to depression except ketamine therapy. And it is also very binary in the sense a patient may have response or may not have response. It's not ki last time I had 50% improvement, this time I am having 45%. No, you had improvement and next session you may not have improvement. Okay. So ketamine therapy is practiced in our ward also. Those interested can join us over there. Then there is vagal nerve stimulation, where repeated small dose of current is given to the vagal nerve. Now 1 in 7 patients are likely to respond to vagal nerve. This is an invasive procedure. But although 6 would not respond, there is somebody who would respond, and that's why this treatment continues to be delivered. Then also you have transcranial direct current stimulation and light therapy. So light therapy is typically used for seasonal affective disorder. So you ask that particular patient that there is a box called light box. It is supposed to emit high dose of light, and this kind of light is placed in the room early in the morning and in the evening hours. So the sunrise is there at, say, suppose 7:30 or 8:30. That particular lamp is switched on at 5 o'clock. And that person is asked to stay in that particular room, do all the activities in that particular room in that bright light. So this also gives improvement in depression. This would be a little bit complicated for you, but you might have seen this in other kind of disorders also. So you have patients who, okay. So this is a person who is normal at that point of time. Over time, the person tends to develop a depressive episode. The symptoms are initially mild. So you just have symptoms, but you don't have a syndrome. At later some point of time, a syndromal picture is developed, and then he reaches you for treatment. At this point of time, you start the treatment. The symptoms reduce. The syndromal picture is no longer there, and then finally a patient reaches normalcy. This normalcy is called as remission. Please remember, this remission is not permanent, and that's the reason why medicines need to be continued for a period of anywhere between 4 to 9 months and on an average of 6 months. So once a person is on treatment for 4 to 9 months, the person is then supposed to have recovered. Okay. Now during these phases, if the person redevelops symptoms, you can have relapse or you can have recurrence. So if you have reappearance of a syndromal picture either during the recovery period or in the continuation phase, it is called as relapse. And if after recovery you have new symptoms, then it is called recurrence. Okay. And this we use for all episodic illnesses, including depression or a manic episode. Okay. So what happens to people who have major depressive disorders? The average length of episodes is about 6 to 9 months. 25% have a length of 1 year or more. So occasionally patients who will have a chronic depressive symptoms. Remember, they reach a syndromal picture. Unlike dysthymia, which is very mild grade, these people will have an episode which can last longer but would remit eventually. Okay. 80% of patients will develop repeated episodes. Over a period of time, the duration between the episodes is going to decrease. So you had first episode 10 years back, right now you're having the second episode. The third episode may happen in 5 years. Okay. The number of episodes in 25 years is about 4, average number. Okay. And if you do not treat these symptoms completely, the likelihood of having a subsequent episode increases. Okay. Patients who do not respond to at least 2 classes of medications are called as treatment-resistant depression, and this is where you are more likely to use biological therapies. Okay. Not every person who commits suicide is having depression. So this is the last point that I want to highlight. About 60% of patients in India and about 90 to 95% patients in the US have been found to have depression when an autopsy, psychological autopsy was done. Okay. So just some FAQs that I want to answer so that you know them and you can answer to your patients accordingly. Does the patient suffer from depression because the mother did not love enough, or the father was not there, or the husband is unfaithful, or there is too much of work pressure, or failed in exam? So do you think this is the reason? Can this be the reason? So this is not the reason. Okay, it is a multifactorial disorder. You can have genes that are involved, you can have early childhood exposure that is involved, you can have events that can lead to depression, you can have events that do not lead to depression. So even if now you are believing that you need some kind of stressor for that particular thing, you are still mistaken. Okay, it is a summation of multiple things, and you cannot put it as a single event that is the reason for depression. Now another thing is people who want to commit. This is typically family members who would say कि अगर इसको मरना ही था तो ये मर जाता, इतना इतना क्यों बता रहा है? So in subtle ways it is भौंकने वाले कुत्ते काटते नहीं है. So if they want to bite, they will bite. They will not keep on barking. Now again, this is very untrue. Patients with depression will usually express their death wish or their suicidal ideas, and this is a warning sign. You have to act so that something bad does not happen. Okay. Another common thing that people will report is इसकी शादी करा दें, will he become better? या हम कहीं hill station पे vacation पे चले जाते हैं, will this become better? So obviously this is not true. In the therapies that we saw, we never saw that we would be giving vacations and the person should get married. This is a form of therapy. Otherwise, psychiatry OPD would also include a tourism office and a marriage bureau. But that is not the case, and this is not the ideal form. This will probably reduce the symptoms, but will not eventually cure the disorder. About treatment, people will ask, are these medicines habit forming? Now, if you look at any other chronic disorder, for example, hypertension, if a person is given antihypertensives, the blood pressure reduces. If you keep on having them regularly, the reduction is maintained. When you stop the antihypertensives, over a period of time, the blood pressure will again rebound and shoot up. Does that mean you are dependent or habituated to antihypertensives? Same thing applies with diabetes. You give a person oral hypoglycemics, the sugar control is maintained. You stop the oral hypoglycemics and then the sugar control is again lost. Does that mean you are habituated to oral hypoglycemics? No. So this is what happens in depression. And the good thing about depression as compared to these two disorders is it is an episodic illness. You manage the episode, you stop the medicines after the episode, you may not relapse into depressive episode. Whereas in case of hypertension and diabetes, years together, and there is never a point where a person says, okay, now you can stop all the medications. Whereas in case of psychiatric disorders, you can definitely say that, look, you've been well on this medication for so long, usually 2 years, we can attempt to stop the medication. So these are not habit-forming drugs. Okay. How long is the treatment required? So this would depend on how many episodes you had. If you had only one episode, treatment duration is less than 9 months. If you had 2 episodes or more, usually 2 years or something, or maybe up to 5 years. Another thing is this care of ECT. An ECT process, if seen, and if you have seen the recovery of that patient, you would understand how important ECT is. ECT does not lead to long-term consequences like memory loss or not able to speak, so on and so forth. So ECT is not at all that harmful. It is de-glamorized quite a lot, but it is a very effective treatment. And then the common thing is the patient comes within 2 days after giving medication, having no improvement, and would insist that you add certain medications. So you need to be very careful. Improvement will start after 2 weeks, not immediately after starting the medication. Okay. Nisba, attendance le लो. So we also have to do bipolar disorders. We can do it briefly some other day. As of now, we wind up at this. Bipolar disorders, I'll try and manage with some other lecture, probably by Dr. Roshan.
Roll number 1, 2, 3, 4, 5, 6,
I card.
7,
I card.
8,
Yo. And yours.
9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 49, 50, 51, 52, 53,
कौन था 52?
54, 55, 56, 57, 58, 59, 60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 80, 81,
एक मिनट कौन? एक मिनट. 80 कौन था? You're 80.
80, 80,
He said he's 80, na?
you're 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93,
Then continue.
94, 95, 96,